patient comes to your clinic and asks you about CLaCS. She has read that it clears leg veins with less bruising and less staining than injections. She may have watched a video of the procedure with the vein map projected onto the skin, the laser, the cold air, and the injection. She wants to know why you're not offering it. You need to know about CLaCS and be able to answer directly. And there's a new paper that addresses that question, a systematic review and meta-analysis that has been accepted in the Journal of Vascular Surgery, Venous and Lymphatic Disorders. And it's the first time anyone has pooled the comparative data on CLaCS against sclerotherapy alone. In this video, I'm going to take you through what that paper found, and I'm going to spend most of our time on something the headline figures do not tell you, which is what the patients in the comparison group actually received. And before we go any further, let me be absolutely transparent and declare my interest. I and the Vein Care Academy teach microsclerotherapy. We don't teach CLaCS. So when I compare CLaCS with an approach that I do teach, you should weigh that. I'm going to try to be even-handed about this, and where the evidence is unfavourable to the position I take, I will say so. So let's get started. So first of all, what exactly is CLaCS? Well, it stands for Cryo-Laser and Cryo-Sclerotherapy, and it combines three things in a single treatment session. It combines skin cooling with air at -20 degrees Celsius blown onto the skin and the needle before, during and after treatment, and immediate injection of a sclerosant into the same vessels. Now here is a detail that I think matters more than it first appears, and I will come back to it. The sclerosant in the original technique is not a detergent. Miyake and colleagues describe using 75% dextrose. That's an osmotic agent, and it was chosen precisely because the laser has already reduced the caliber of the vessel, so theoretically a less aggressive agent is sufficient. Hold on to that thought. The rationale for the whole technique is reasonable. The laser produces endothelial injury and vasospasm. The vessel narrows, and you may then be able to use a smaller volume of a milder sclerosant and provoke less inflammation than you would with injection alone. That is a good reason to test the technique. It is not on its own evidence that the technique works better than microsclerotherapy alone. So what did the new analysis find? It searched PubMed, Embase and Central to February 2025 and included 6 studies covering 813 patients or treated limbs. Two things about that description deserve your attention before we get anywhere near the results. First, the design mix. 6 studies sounds substantial, but that is 3 randomized controlled trials, 1 prospective non-randomized comparative study, and 2 retrospective single-arm cohorts. And only 3 of the 6 actually compared CLaCS against anything. The other 3 had no comparison group at all. So every pooled figure in this review rests on 3 studies, and one of those 3 is not randomized. Second, the search date. The literature search ran to February 2025, and the paper is dated 2026. That's a gap of roughly 18 months in an area of research where individual trials usually arrive at the rate of about 1 a year. The review itself is pretty candid about its limitations. It reports risk of bias concerns across multiple included studies, substantial heterogeneity on several endpoints, and it could not assess publication bias at all because no outcome had 10 or more studies. So I want to make one point about evidence grading here, because pooled data from a meta-analysis is sometimes labelled level 1A as a matter of course, simply because of the study design on the cover. Now, I don't think that label survives scrutiny here. A pooled estimate drawn from 3 studies, one of them non-randomized with acknowledged risk of bias and high heterogeneity, is evidence from meta-analysis, but with obvious reasons to downgrade our confidence in it. It's better than what we had before the publication, but it's not the same thing as a large, low-bias, replicated, randomized comparison. And if you're making a purchasing decision on the strength of it, that distinction and difference really does matter. So let's turn to the results. Against sclerotherapy alone, the meta-analysis reported 3 statistically significant reductions. Now, a risk ratio below 1 means fewer events with CLaCS, and in all 3 cases, the confidence interval does not cross 1. So these are statistically significant reductions and not chance findings. They are also large differences. Taken at face value, that looks like a clinically significant result on 3 problems that patients notice and complain about. So far, so encouraging. But when you read the largest trial in detail, that is where things get interesting, to say the least. The largest included trial is by Nasser and colleagues at Cairo University Hospitals. They randomized 400 patients, 200 to each treatment arm, and analyzed 195 and 197 after 8 were lost to follow-up. This single trial supplies most of the events behind those pooled figures, so its method deserves close reading. Group A, the CLaCS arm, received ND-YAG laser at 50 to 70 joules per square centimeter with continuous cooling. Then 12 to 15 milliliters of 70% dextrose through a 30-gauge needle. No compression afterwards, and a hirudin-based gel twice a day for a week. Group B, the comparison arm, received 8 to 10 milliliters of 0.5% polydocanol foam prepared by the Tessari method into the same 20 centimeter by 20 centimeter field. Then compression stockings for a week. Let me say that again because this is the heart of the matter. The comparison was not CLaCS against microsclerotherapy. It was CLaCS against 8 to 10 milliliters of 0.5% polydocanol foam delivered into a single 400 square centimeter area of cosmetic C1 disease. Now look at what happened to those patients. In the foam group, 77.7% had moderate pigmentation at 8 weeks. 9.7% had severe pigmentation, matting in 19.3%, microthrombi needing thrombectomy in 36.5%, ecchymosis in 45.7%, and skin necrosis in 4.2%. Total complications? 78.7%. Now, I want to be fair to the trial here. Pigmentation did settle substantially over time. Over 6 months, it fell from 77.7% to 45%, and the authors reasonably point out that the 8-week figure partly reflects how early they reviewed these patients. But a 45% pigmentation rate at 6 months is still very high, and a 4.2% skin necrosis rate in patients who came for a cosmetic treatment is a number that should stop you. Think about it. Those are not the numbers that careful liquid injection at the lower end of the guideline range, in terms of concentration, should be producing, and I will come back to that protocol a little bit later. So what the largest trial in this meta-analysis shows is that CLaCS was compared against a sclerotherapy protocol that performed poorly. It's not a protocol that a lot of us would use, and it's not possible to tell from these data how much of the difference reflects the laser and how much reflects foam at that concentration and volume with no evident titration. The trial authors are open about part of this, they attribute the lower complication rate in the CLaCS arm partly to dextrose being milder than polydocanol. What they do not address is whether a detergent foam at that concentration and volume was the right comparator in the first place. 3 variables were moved at once, and 3 things follow. First, that matting figure. The risk ratio of 0.07 rests on a trial where one treatment arm had no events at all. No matting in 195 CLaCS patients against 38 cases in 197 sclerotherapy patients. When one arm records 0 events, the ratio cannot be calculated precisely, and that is why the confidence interval is so wide. Instead, we should read 0.07 as much less matting in this trial. Do not read it as a treatment effect size to quote to a patient. Second, the treatment arms differed in aftercare as well as modality and sclerosant. Group A had no compression and a topical antithrombotic gel. Group B had a week of compression stockings. Retained thrombus is an important driver of staining, and the 2 arms managed it differently. So 3 variables were moved at once: the laser, the sclerosant, and the aftercare. Third, and most importantly perhaps, this is a comparison between a hybrid technique and one specific sclerotherapy protocol. It's not a comparison between a hybrid technique and what we would consider best practice in microsclerotherapy. Those are different questions, and only the first has been answered. Now let's talk about pigmentation, because this is where the story gets really surprising. And a quick word on terminology first. Many trials record their outcome as hyperpigmentation. Strictly, hyperpigmentation means excess melanin production. What we see after sclerotherapy is a combination of melanin and hemosiderin. So post-sclerotherapy pigmentation is the better term, and that distinction is not pedantry, because a trial measuring color change is capturing 2 different processes with different time courses. Here's the logic. If CLaCS produces fewer microthrombi and retained intravascular blood is a recognized precursor of hemosiderin staining, then CLaCS should produce less pigmentation. The meta-analysis makes exactly that argument, and it's a reasonable one. The data do not support it. The pooled estimate for pigmentation was not statistically significant, and heterogeneity was very high. The cleanest study in this area shows you why. Rodriguez and colleagues ran a within-patient randomized trial. Reticular veins were treated with CLaCS on one limb and 0.5% polydocanol foam on the other. Same patient. Blinded evaluators, 60 days after a single session. No significant difference in the number of limbs developing pigmentation. 7 versus 5 by photographic evidence. 9 versus 13 by colorimetry. The CLaCS side did show significantly lower pigmentation intensity on colorimetry, a difference of 0.14 delta E with both values close to the threshold at which a color difference becomes perceptible to the human eye at all, is a statistically significant difference of doubtful, visible, and clinical consequence. That's my interpretation, not the author's conclusion, and colorimetric thresholds are not settled. But your patient is asking, will there be less staining? She's asking about what she can see in the mirror. And this trial doesn't clearly answer that question with a yes. So, CLaCS has not been shown to reduce pigmentation, despite a good biological reason to expect that it should. Personally, I find that really interesting, and it's the part of this evidence base I would like to see settled. And now the outcome your patient is actually paying for: clearance. The review could not pool it at all. The included studies defined and measured clearance in ways too different to combine. So the authors described their findings one by one instead of calculating a single figure. That is the single most important limitation of this evidence. The individual studies point in different directions. NASA reported markedly better complete elimination with CLaCS across 3 sessions. Rodriguez found no difference in diameter reduction between the various treatment limbs. Those cannot be reconciled into one number, and the review was right not to try. So where does this leave us? Currently, there is no pooled evidence that CLaCS clears leg veins better than optimized microsclerotherapy. What the evidence suggests is that it may clear them about as well, possibly with fewer visible side effects in the short term. Those are 2 different claims. Please do not blur them together in a consultation with your patient. So now let's turn to the practical question. And let me be clear, it's not, is CLaCS better than injecting? It's whether CLaCS is the treatment option worth spending a substantial equipment budget on. Because CLaCS is not one machine, it's 3. An ND-YAG platform, a cold air skin cooling system, and an infrared vein imaging device. In the NASA protocol, that meant an Alma lasers ND-YAG, a Zimmer cooler, and a vein viewer flex. Plus, you have to have competence in both laser and the injection treatment. No economic analysis has been done, and the meta-analysis doesn't offer one. Reducing visible short-term sequelae is clinically worthwhile, but it's not the same thing as cost effectiveness, particularly when the comparator against which those reductions were measured is a protocol most of us would not use. So let me set out what optimized microsclerotherapy actually looks like, because it's not what the comparator arm in that trial received. Concentration within the guideline range and at the lower end of it. Polydocanol 0.25 to 0.5% for telangiectasia, 0.5 to 1% for reticular veins, liquid, not foam, for spider veins and thread veins. Foam increases the effective dose reaching the endothelium, and it travels further from the injection sites. Small volumes confined to a small area from each puncture. Accurate, superficial injection with blanching of the vessels as your endpoint, avoiding blanching of the skin or bleb formation. Review at 2 weeks to release retained coagulum if it's present. Retained thrombus is the substrate for hemosiderin staining, and early release is one of the few post-procedural steps with randomized support and trial evidence behind it. Compression where indicated, individualized rather than routine. Sun avoidance while the inflammation settles, because ultraviolet exposure during that phase may drive melanin component pigmentation. That one costs nothing, of course. Now set that list against NASA's comparison arm. Foam, the top of the guideline range, 8 to 10 ml across a 400 square centimeter field. No interval review. So the question the evidence answers is, does CLaCS produce fewer short-term adverse events than that protocol? And the answer appears to be yes. The question you are actually asking is different. Does CLaCS produce fewer adverse events than careful liquid microsclerotherapy injection at 0.25 to 0.5% in small volumes, with review at 2 weeks and sensible aftercare? Nobody has studied it. That's not a criticism of CLaCS. It's a statement about what we do not know, and it's why this evidence cannot yet guide a purchasing decision. So what do the guidelines say? And it's important we deal with the guidelines, because you will hear CLaCS described as being in the ESVS guidelines. The NASA paper states that CLaCS has been incorporated into the ESVS clinical practice guidelines. Now, I've read the guideline text, and that is not what it says. CLaCS appears in the body text of the ESVS 2022 guidelines exactly once in section 4.5.3 on hybrid techniques in a single sentence, calling it a new option with promising results and stating that more studies are required for its validation. That's a mention with a caveat. It's not an incorporation. Here is what the ESVS actually recommends for these vessels. So let me bring this all together. The most effective and safe route to less matting, less trapped blood, and less staining is not a machine. It's the lowest effective concentration of sclerosant. It's accurate superficial injection. It's small volumes at each injection site. It's reviewing at 1 to 2 weeks to release retained coagulate. And clear advice to your patient to keep the treated area out of the sun while it settles, because UV exposure during the inflammatory phase does drive melanin to increase the pigmentation, and it costs nothing to prevent. So you might want to buy equipment when it does something injection really cannot do for that patient, but don't buy the equipment to compensate for a protocol that you could correct quite easily. Now, to be clear, I'm not telling you CLaCS doesn't work. It might have a place in a specialist practice where minimizing matting, microthrombi, and bruising is a stated priority for a particular patient, for example. For patients who have had cosmetically troublesome sequelae after standard sclerotherapy, in settings that already have ND-YAG capability, cooling, and it has operators competent in both laser and injection. And it might have a place in selected patients where an experienced operator judges it useful, provided the consent conversation says plainly that superiority is unproven. What is not supported is CLaCS as a first-line replacement for all uncomplicated leg spider veins, or any claim that depends on long-term recurrence prevention or independent replication, because neither of those exist. One more thing on the evidence base. The comparative data comes mainly from Brazil and Egypt, and there is direct author overlap between the meta-analysis and at least one of the trials it includes. Now, I'm not suggesting there's been any misconduct. That overlap is common and often unavoidable in very specialized areas of research. I'm just making a point about the relative lack of independent replication, and independent replication is what should determine our confidence in any new technique. At present, a clinician relying on this evidence is relying largely on a single investigator network. That is a reason for measured adoption, not for suspicion, and it is exactly the gap that a trial run by a different group in a different country might close. So to summarize, the 2026 meta-analysis is a real and significant contribution to the literature, and it's the first pooled comparison we've had so far. It reports less matting, fewer microthrombi, and less bruising with CLaCS. It doesn't show reduced pigmentation, and it could not pool vessel clearance data at all. And the largest trial behind those figures compared CLaCS not against liquid microsclerotherapy, but against a foam protocol that produced complications in 78% of patients. For me, liquid sclerotherapy at the correct concentration remains the first choice for leg telangiectasia, and that is exactly where the ESVS guidelines put it, at Class 1, Level A for reticular veins. The full article, including the evidence tables, the guideline positions, and all the references, they're linked in the description below. Now, I hope you found this useful. If you did, please give it a like and consider sharing it. That way it will get the message out, and it really does help my channel. Why not consider subscribing? And that way you won't miss my next video. My name is Dr. Haroun Gajraj. Thank you for watching.